Yeah, I think that's a great question. So we know that for children diagnosed with cancer, that they're at an increased risk of developing another cancer later on. And so we do have very good clinical guidelines that recommend earlier cancer screening for those populations, depending on the treatment they had. So, for example, children or adolescents who had chest irradiation should commence breast cancer screening at age 30 or 8 years after completing that therapy. For these young adults, we actually don't have those clinical guidelines, and I can't say for certain what we should be doing. I think the results from this study are just trying to open up that conversation, saying we know that the children have increased risk and that they commence screening earlier, but we don't really know for these adolescents and young adults what is correct. We still need to look at those detailed treatment exposures to understand who is at greatest risk and who will benefit most from screening. I think right now what we can say is for these adolescents and young adults, they should be having conversations with their family physicians, and that oncologists should be trying to educate the survivors as much as possible with the information they have, as well as the family physicians too, so that they can have appropriate surveillance afterwards. Yeah, so we know that irradiation treatment is the greatest risk for another cancer, and that's because radiation causes cancer regardless of if you're a cancer survivor or not. So having chest irradiation will increase your risk of breast cancer and potentially lung cancer later in life, whereas having pelvic irradiation we know is a really strong risk factor for colorectal cancer later. Other types of treatments that we know increase risk of another cancer can be hormone therapy, which is often used to treat breast cancer as a first cancer. And then also, we know that some chemotherapy agents can also increase cancer risk later on too. I think that's exactly the question that we need to be exploring. So right now, this study doesn't really get to who are the most high-risk individuals. We kind of looked at treatment, diagnosis groups, but what we really need to dive in further is to look at the specific treatments individuals received. And so that's the next study we hope to undertake. But the idea is if we can identify a very precise population who is greatest at risk, we can then explore what would be the benefits and the harms of starting those treatment screenings for breast, colorectal, or lung cancer, where we already have existing infrastructure in our province, at least of Alberta, and but in many other settings too. So that would be the analysis we would have to explore to say, okay, we identified these individuals who are at increased risk. How early should we start treatment? And if we were to do that, would the benefits of detecting some cancers earlier or preventing them altogether in the case of colorectal cancer, do those benefits outweigh the harms of false positives or distress? And that would be the important information we need to get to policymakers to decide the best way to support these people during their survivorship care. I think that is such a critical question because a lot of the questions I've been asked since this study is, okay, what do we need to be doing now? We don't have all the answers now, but what we know is what causes cancer for everyone. And this is going to be true for these adolescent and young adult cancer survivors too. So ensuring that you don't use tobacco, that you limit your alcohol or do not drink alcohol at all, you maintain a healthy body weight, you put sunscreen on, all of these are going to be important things that are in your control to reduce your risk of developing another cancer later in life. Unfortunately, I think sometimes these simple things that we think everyone knows doesn't always don't always get transmitted to these young survivors. And so they may think, oh, I've had a cancer already. I'm not likely to have another one. But really engaging in these primary prevention, modifiable lifestyle factors is critical to decrease future cancer risk for everyone. Yeah, I mean, I think we're quite fortunate here in Alberta. So I will probably primarily talk about that. But in our province, anyone treated in the pediatric setting, so that's pretty much under age 18 at diagnosis with a cancer, has the opportunity to be followed up for life. And so that means they are getting specialized care, they are getting told what their risks are, and they're being followed up appropriately depending on how how great those risks are. I think the issue is actually when people stop engaging in that service or never partake in it in general. That means that they could have information and they could be followed up by these experts, and maybe their family doctors are not getting that information sent to them because they never engaged in that long-term survivorship care. So I think ensuring documentation is in the records. In Alberta, we do have electronic medical records that are connected for every patient. I think that's really critical to make sure any of these gaps in care, any of these transitions, that those notes are there and that the new family doctor can be following. I think we need to recognize young cancer survivors are like any young person in general. They're a very mobile population that is moving for education or for work. And so trying to think about how we can build upon existing infrastructure like electronic medical records to ensure continuity of care is really critical for this population, both here in Alberta, more widely in Canada, but also in the US.